Hello, I'm Dr. John Bennett, broadcasting from sunny Miami. Today we have the pleasure of having an old regular, Bernardo de Andrada, a neurosurgeon from Rio de Janeiro who specialized in spine surgery. He's going to talk about intracranial meningiomas today. And we have one guest today. We'll first introduce him, and we'll turn it over to Bernardo. Hello. Hello, Slaven.
Hello, I'm very glad to be here. My name is Slaven Bojkovic, medical student from Croatia, and I'm enjoying the lecture.
Okay, well, welcome, Slaven. Okay, welcome, Bernardo. It's all yours.
Oh, thank you so much. Hello, John Bennett. Hello, Slaven. I'm very glad to be here, and thank you again for inviting me to speak. Today, we are going to talk about intracranial meningiomas. This is the tumor I most frequently operate. So we will talk a little bit.
Okay.
Are you seeing?
Yes,
okay.
We can see it. Yes.
So my name is Bernardo de Andrada. I live in Rio de Janeiro. I practice medicine in Rio de Janeiro. I'm on Facebook in my page, blog the Neurosurgeon, and I'm on Twitter on email too. This is the hospital I work in Rio de Janeiro. And meningiomas are slow-growing in extra-axial, usually benign tumor, and it arises from arachnoid tissues. They arise when there's arachnoid cells. In 2014, FALX Plater first described a meningioma in an autopsy report. It's very common to find meningiomas in autopsies because a lot of them are asymptomatic. And 754 French surgeon Anthony Lois publishes the first reports that attend specifically with meningiomas, and we have the first case relating prior head trauma to casualty of meningioma involved General Leonard Wood, Major General and Chief of Staff of United States Army. In 1910, Cushing successfully performed this surgery on General Wood's parasagittal meningioma. A few weeks ago, we had a hangout about Cushing life, and he performed this important surgery. Meningiomas may occur anywhere arachnoid cells are found in our body, most frequently seen in intracranial, but we can found meningiomas in spine too. Usually they are slow-growing, well circumscribed, and benign. We just found 1.7% malignant meningiomas, as known as anaplastic. These kinds of meningioma has happily growing. So we have happily growing meningiomas also described that corresponds in most parts of malignant or anaplastic meningiomas. And in some cases, usually forms a diffuse sheet of tumor we call meningioma in black. In some cases, they can be multiple. In 80% of cases, we can find more than one meningiomas. So epidemiology, we are talking about 3% of all autopsies in patients more than 6 years reveals a meningioma, so it is frequently found on autopsies. It accounts for 19% of intracranial neoplasm. The meningiomas has a peak of incidence. It's about 45 years. Female-male ratio is 1.8 to 1. and 1.5% occurs in childhood or adolescence. In adolescents, 24% are associated with von Hicklinghausen's disease, as known as neurofibromatosis type 1. And we can talk about neurofibromatosis. Neurofibromatosis type 1, we call NF1, is not associated with an increased risk of meningiomas, but whether meningiomas are part of the schwannomatosis tumor phenotype or not remains debated. So we already talked about NF1. 34% of meningiomas in adolescents are associated with this disease. And neurofibromatosis type 2, we frequently see meningiomas. They often can be multiple, and we see associated with acoustic bilateral neuroma. About half of patients with NF2 occurs meningiomas. They are often multiple. Now we will talk about locations of meningiomas. It's a very important topic because although they are benign lesions, depending on the locations, they could be not good prognosis. About 70% occurs along FALX, convexity, or sphenoid bone, and other 30% occurs in other locations. So about 20.8% are parasagittal, occurs along FALX. The 15.2% occurs on convexity. 12.08 occurs in tuberculous SELLA. 11.9 sphenoid ridge. 9.8% in olfactory groove. And 80% FALX are attached on FALX. Lateral ventricle 4.2%. 3.6% tentorial. And other locations include CP angle, cerebellopontine angle, clivus, foramen magnum, orbital meningiomas, spinal, and intrasylvian meningiomas. The foramen magnum meningiomas is a challenge because we have a lot of neural and vascular structures close, and CP angle too, and so let's talk about convexity meningiomas. Grow on the surface of the brain directly under the skull. Tumor whose attachment does not, the convexity meningioma are tumors whose attachment does not occur in the dura of the skull base or does not involve the dural venous sinus or falx. They account for approximately 20% of meningiomas. We can find many different symptoms like hemiparesis, seizures, aphasia, visual impairments if they are on occipital lobe, and can involve dura and bone of cranial vault. It's an example of convexity meningioma. This is lesion. This is a dural attachment on the convexity of the skull. Meningioma. It arises from this bone of the convexity. Sphenoid wing. We can call the sphenoid wing meningiomas in lateral, middle thirds, or medial. Lateral, we as known as pterional meningiomas, we treat like convexity meningiomas. Is similar, the behavior. And the middle third, as known as LR, and the medial one is more complex. because it can encase the internal carotid artery, middle cerebral artery, and cranial nerves involved on cavernous sinus and superior orbital fissure, and they can compress brainstem too. So they are a little more complex. It's an example of lateral sphenoid wing meningiomas. It involves middle cerebral artery and nerves and cranial nerves of the superior orbital fissure. So patients present with oculomotor paresis or visual impairment, or sometimes ophthalmoplegia. Parasagittal and FALX meningiomas, half of them invade the superior sagittal sinus. They can be anterior, in anterior thirds, to reclassify the parasagittal meningioma in anterior, middle, or posterior. Anterior, when they arise from ethmoidal plates to coronal suture, they can present with headache and mental status change. When it arises from coronal suture to lambdoid suture, we call middle. It's about 50%, and we can find patients with symptoms of monoplasia, and patients can present seizures. In posterior, when they arise from lambdoid suture to turcular aerophily, and they can present with headache, visual deficit, focal seizure, or mental status change. The posterior can be very big because they became symptomatic later. This is an example of parasagittal meningioma. It attaches on FALX, meningioma is attached on FALX. We call parasagittal meningiomas. And complications of this kind of surgery is bleeding from superior sagittal sinus or inferior sagittal sinus, mainly superior sagittal sinus. Lesion in superior sagittal sinus can provide hypovolemic shock. Another complication is occlusion of this sinus, this dural venous sinus. It can bring edema and mass effect. Another complication is hemiparesis, hemiplegia, venous infarction, anterior cerebral artery bleeding, or thrombosis and seizures. It's the more often seen complications of this surgery. But I think the most important, we always should be careful, is bleeding of superior sagittal sinus. Olfactory groove meningiomas. They usually giants because they become symptomatic later, and we can find patients with Foster-Kennedy syndrome. It represents ipsilateral optic atrophy and contralateral papilledema. So we have one in the side with the tumor is grow more. We have papillar atrophy, and on other sides we have papilledema due to intracranial hypertension. And these tumors often presents with anosmia and mental status change. I think the most common findings is anosmia and mental status change, with frontal lobes findings like apathy, abulia, urinary incontinence is very common too. This is the meningioma that arises from olfactory groove. This is a tumor, It can have correspondence with the anterior cerebral artery, so we should be careful when remove these meningiomas to avoid bleeding or thrombosis of anterior cerebral artery. And the difference between olfactory groove and tuberculous SELLA meningioma is about 2 centimeters. The tuberculum SELLA meningioma arises 2 centimeters posterior of olfactory groove meningioma. That this example is the olfactory groove meningiomas. And the surgery is the surgery of olfactory groove have many complications too, and to remove totally this tumor is very hard because this tumor often bleeds, and it's difficult to achieve total removing. It's common CSF leak, mainly nasal CSF leaks from nose. We can find meningitis often associated with CSF leak. Another complication is deep venous thrombosis on legs, because meningiomas can cause hypercoagulability state. So these patients have more frequently thrombosis. And another complication is ACA bleeding, anterior cerebral artery. And this deep venous thrombosis is a systemic complication, are not directly associated with the procedure, but I want to put it on the slides because I think it's very important to pay attention and the prevent. And another complications are local complications like anterior cerebral artery bleeding, thrombosis with this ischemic effects. We should avoid the internal carotid artery and middle cerebral artery lesions too. In tuberculum SELLA meningiomas, the size of origin is only 2 centimeters posterior. That's olfactory groove. It produces visual loss too, and in my point of view, it's a very complex tumor because it can involve internal carotid artery and optic nerve and oculomotor and another cranial nerves. Complications includes pituitary and hypothalamic postoperative impairment. So this tumor, I think, is very complex too. This kind of meningioma. Another kind of complex meningioma is foramen magnum meningiomas. The neurological symptoms and signs may be confusing. They can present with very different symptoms and signs, and it can arise on anterior lip of magnum foramen in 31% of cases, in lateral lip in 65%, in posterior in 13%. And more usually they are intradural, but in some cases it can be intra and extradural. It's very close to medulla oblongata and the lower cranial nerves and vertebral artery. And it's very complex because they are very close to these structures, very important structures like vertebral artery, posterior inferior cerebellar artery, lower cranial nerves, and medulla. The more frequently used approach is called posterior lateral approach, also called the far lateral approach, when we can drill or not the posterior third of occipital condyle. Complications of foramen magnum surgery includes the vertebral artery injury, bleeding or thrombosis, impairment of lower cranial nerves, and brainstem damage. This is the the picture show different locations of meningiomas. This is an intraventricular meningiomas, and convexity meningiomas can arise at this dura of the cranial vault here. And here we have the FALX, and this is a parasagittal meningioma. It can be attached on FALX or on dural vault. We have a falcine meningioma, and here we have an olfactory groove, a supracellular 2 centimeter posterior parasagittal meningioma. Cerebellar, we can usually find meningiomas in posterior fossa or cerebellopontine angle. Foramen magnum. And clevus is very difficult to approach this tumor located on clevus. This picture I took from website of John Hopkins Medicine, and a lot of meningiomas are asymptomatic, so we call incidental meningiomas when patients routine use a CT scan or MRI for another thing and found a meningioma. Usually these patients had a minor trauma or do this exam due to headache. So we found an incidental meningioma. So we have to decide between surgery or just watch. And these decisions, I think, is personally. So 60% showed no increase in 1 year of these cases. So we can watch. In many cases, we can just watch this meningioma. And if it became larger, if it's growing, we can decide to perform surgery. I agree that the decision to perform surgery or not involves age of patients, the locations of tumor, and comorbidities. These patients have comorbidities or not. So we have to decide personally if we are going to treat with surgery or just watch these tumors. So let's talk about pathology. The most common type of pathology of meningiomas is the meningotheliomatous type or syncytial. We have fibrous or fibroblastic when cells are separated by connective tissues, and we have the transitional forms, is the intermediate between syncytial and fibrous. And we have two other variations, like microcystic, psammomatous, angioblastic, atypical. We classify it as atypical when you have increased mitotic, 1.1 or 2 figures for high-powered fields. We have high cellularity and focal necrosis. We can classify as atypical. And we have malignant, as known as anaplastic. We have frequent mitotic figure, rapid recurrence, even if totally removed. Rarely metastasis is common in young people. So this malignant meningioma usually grows faster, and even if you remove it totally, it frequently recurs, occurs again. Evaluation. So MRI show most meningiomas on T2 weighted image, and it can predict sinus involvement, and we often see a dural tail. On CT, we see homogeneous mass, densely enhancing, and broad base of attachment along dura, and we often see edema of the white matter associated. In angiography, we usually need angiography to assess the patency of venous sinus and some arteries. In some cases, meningioma is very bleeding tumor, so we need to perform a preoperative embolization, and we need to study the feeding of the arteries of this tumor. The most common feedings artery of the meningiomas is from sternal carotid artery. And when we see arterial angiography in patients with tentorial meningiomas, we see an enlarged tentorial artery that we call Bernasconi casinary artery or Italian artery. It's very classic of tentorial meningiomas, an enlarged tentorial artery that we call Bernasconi casinary artery. And surgery. The treatment of choice for symptomatic meningiomas is surgery. And they usually can be totally surgically resected and result in a permanent cure. They often can be very bloody. Transarterial embolization has become a standard preoperative procedure in the preoperative management. It's rare for benign meningiomas to become malignant. So I always put the heads on Mayfield to avoid moving heads, and always use scope to find the artery feedings to coagulate to avoid bleeding. So we have a lot of approaches for meningiomas. Sphenoid meningiomas, we usually use a pteronal approach or orbitozygomatic approach. When we have a parasagittal or FALX meningioma, we use interhemispheric approach. A petroclival meningioma, we can use orbitozygomatic, pre-sigmoid or heterosigmoid approach. For olfactory groove, we can use a bifrontal or frontolateral, depending on the size of tumor. In foramen magnum, we use a forlateral approach with drilling or not the posterior thirds of occipital condyle. Sorry. So outcome, Mirimanov et al. Reported recurrence-free survival rates following total resection of 93% at 5 years. So extent of tumor removal predicts outcome. Gross total removal provides cures in the majority of cases. So when we are going to operate a meningioma, we always should try to achieve the gross total remove. And we have the SIMPSON grade system to classify the removal of the tumor. I will show. And malignant meningioma have high recurrence rates. So let's talk about SIMPSON criteria. Is very famous for a neurosurgeon who operates meningiomas, because the criteria measure the probability of a tumor recurring or growing after surgery, and may be estimated by comparing the tumor's World Health Organization grades and by the criteria and by the extent of surgery by the SIMPSON criteria. So there is SIMPSON criteria. We have SIMPSON 1 when we complete removal the tumor, including resection of underlying bone and associated dura. In this case, we have a 9% of recurrence in 10 years. So it's a very low. Actually, when we achieve a total remove, when we achieve a SIMPSON 1, actually these patients can be considered cured. And the SIMPSON 2, when we complete removal and just coagulation of dural attachments, we do not remove the dural attachment, we just do the coagulation. And SIMPSON 3, when we have complete removal without resection of dural or coagulation, we just remove the tumor and keep the dural attachments, did not do the coagulation. In SIMPSON 4 is a subtotal resection, and sometimes we hear about SIMPSON 5, there is only a biopsy. It's beneficial in partially resected meningioma. So when you have a meningioma that you could not remove all tumor, you can send these patients to radiation therapy to control the residual mass. But in some cases, it's possible to simply follow these patients with partial resected meningiomas without radiation therapy in some cases. We always should pay attention in side effects of radiation therapy, like radionecrosis and like malignant glioma. It's when you have radiations of neural tissue, we have risk of malignant glioma. So I bring a few cases to show you. The first case, we are talking about a female with 50 years. She only had a headache and one seizure, just one seizure, and did a CT scan. We found the right frontal falcine meningioma. We did a frontal interhemispheric approach with total removal of these lesions, and we followed these patients for 2 years, and she's very well. She is asymptomatic now. This is a frontal mass. We assess and remove all mass. Is the approach. The head is on the Mayfield clamp. And here is a post-operative CT scan with total removal of the mass. Actually, this we achieved SIMPSON 2. We coagulated the attachments that was on FALX, and this patient is very well. In case 2, it was a male, 62 years, with left hemiparesis and headache. CT, we found a frontal parasagittal meningioma. We performed the surgery with total removal. In this case, we have, after 72 hours, a huge edema with these patients becoming hemiplegic, but we treated with dexamethasone and it recovery. We followed these patients for 3 years and he's very well too. This is a lesion attached on FOX. We have an edema associated with the lesion. Here's the sagittal view of the tumor. Here's the surgery, the incision, and total removal of the tumor. And the patients go well too. In case 3, we have a male, 60 years, with right hemiparesis and seizure, right weakness. CT scan showed a frontotemporal convexity meningioma. So we could achieve a total removal with surgery and no recurrence in 2 years follow-up. This is the pre and post-operative CT scan. We have a large mass that was entirely removed through the frontotemporal craniotomy, and this patient is very well. And another case, we have a female with 74 years presenting with confusion and mental impairments, mental status change. CT scan showed a frontal falcine meningioma, large, very large meningioma. We have a axial, coronal, and sagittal view. The mass was displaced in the ventricular system. This is a post-operative CT scan. Another case, now a female with 64 years, headache and mental status change. She had interhemispheric frontal meningioma. It was attached on FALX too. It's very huge. So these patients had some complications on post-operative, like pulmonary infection, deep venous thrombosis. She had gastroduodenal bleeding. She has she had to insert a filter on the vein, in cava vein, to avoid thromboembolar pulmonism. And after 1 month of hospitalized, she was discharged and she is well. Now, just with some frontal findings, like a little apathy, but it's good. It's fine. Thank you for attending.
Okay, Bernardo, thank you very much. Another well illustrated slides. It looks like you put a lot of work into that, man. I really appreciate it. I have a couple of questions here.
Oh, nice.
How often do you encounter the sagittal sinus bleeding during your operations?
So, just let me turn off the screen share.
Oh, okay,
just
yeah.
a moment.
Yeah. Okay.
Now are you seeing me?
Yeah.
All right.
Yep.
How often I see a superior sagittal sinus bleeding?
Bleeding, yeah.
Yeah, it's sometimes we see it's not too frequently. The most part we have not bleeding.
Really?
But sometimes we had. I had one case in about 1 month. I didn't bring because this case is we are going to reoperate these patients. In this case, we had to stop surgery because of bleeding and wait the patient recovering. And now we are deciding what we are going to do with the rest of the mass that it keeps in size. Because in this case, we should stop because the mass invades the superior sagittal sinus. And when we start to handle these parts of attachments, we have continuous bleeding. It becomes a hypovolemic shock. So we decided to stop. And I'm a neurosurgeon for 80 years. I see a meningioma surgery. I'm seeing for 80 years, and I already see these cases about 3 or 4 times. But the most part of cases we don't have. We can, if we have a small bleeding of superior sagittal sinus, we can control it with cottons, with wires, so we can control the bleeding. But in some cases we cannot control, and it's very difficult situation
Well,
because
you know, these you know, I'm not a neurosurgeon, but it seems that these tumors, they're basically benign, but their location can make them almost like malignant,
yes,
almost as bad as a malignant tumor.
yes, yes. I think the most difficult locations for these to approach meningiomas is petroclival meningiomas, because it may involves cranial nerves, carotid artery, and the approach is difficult. And sometimes you should do a pre-sigmoid approach when you should drill portions of petrous bone. And the risk of this approach is facial palsy and lesion to auditive nerve, to vestibular cochlear nerve. And foramen magnum meningioma is the location is very difficult too, because there is close to many structures, and depending on the patients, the surgery is very, it has not a good outcome, has a bad outcome. They can have complications, and but the most part of meningiomas is parasagittal or convexity,
Right.
or sphenoid bone meningiomas, and
Fairly
it's more
straightforward to remove.
yeah, it's more accessible, it's more feasible
Right.
than another ones.
Slavin left a question. He had to go to sleep. It's like 4 in the morning over there. He asked, "Is the Professor Rotan's rule go 2 steps in front and 1 step behind of the coronal sutures when you perform the parasagittal craniotomy really useful in keeping from venous bleeding?" Do you know what he means by that?
I didn't understand the first part of the question, just the first part.
Professor Rotan, you know him, right?
Yeah, sure.
Yeah. He says, go 2 steps in front and 1 step behind of the coronal suture when you perform the parasagittal craniotomy. Is it really useful in keeping from venous bleeding? Does that make sense or no?
Yeah, I think yes, because I think when we see a structure, we are more safe to fix some damage if you have, So I like to always expose the sagittal sinus to avoid lesions, to avoid bleedings, because if you have bleeding on superior sagittal sinus, your entire surgery will be affected, know, because you have a large bleeding in the beginning of the surgery. So it affects.
It's a bad sign.
Yes, exactly.
Well, yeah, just being around medicine and hearing someone had a brain tumor, but thank goodness it was just a meningioma. But still, it could be dangerous because of the location. You're not in the clear if you're told you have a meningioma. It depends where the meningioma is at.
Yes.
To determine about how serious it is.
Yes, when you have school-based meningiomas, is not
no problem.
No, it's not good meningiomas to assess. You know,
Oh,
you
okay.
have many complications, and I think the most friendly meningiomas is the convexity meningiomas,
Convexity. That's a good
because
one. When you're glad to see
yeah,
that.
the surgery usually go well with few complications, you know,
Right.
and
Right.
you can achieve a total removal with safety. When you have internal carotid artery involved, or sagittal sinus involved, it's more difficult to achieve the total removal, you know.
Right. Right.
Sometimes you should keep a piece of tumor there and just watch after, or send these patients to radiation therapy, you know. So we should to analyze personally each case, and to know where you go, when you go more, when you will stop, you know,
Mm-hmm.
to avoid morbidity, to
Oh,
avoid morbidity to these patients.
morbidity. Okay, Bernardo, thanks a lot for taking the time
Okay,
from your busy schedule, and we'll put another one on your resume for the talk.
thank
And
you so much, John.
I'll send you the video the recording, and it was another excellent presentation. I really appreciate it, Bernardo.
Thank you,
And
John.
you're welcome. Any hangouts tomorrow, you're welcome. Just send me by Facebook. I want to sit in the panel for tomorrow, and you're welcome.
Okay, I will.
Okay, Bernardo.
Bye.
Take it easy. Bye bye.